So this is kind of the things that we'll cover once we get by the end of the PowerPoint. You should kind of understand of what EPIC is, kind of what the study of all of it was, and kind of how that relates to treatments that primarily pre-hospital and like emergency departments are doing to kind of increase survivability of brain injuries. So, next please. So these are just some stats for you of like nationwide traumatic brain injury every year throughout the country. So throughout the country, you're having just a little over 2 million TBIs, about 500, or is that the number? Yeah, about 200 to 300,000 of those require some kind of hospitalization, and then 50 to 60,000 of those will actually result in death. And there's so many different variables that actually will cause that death, and that's kind of a lot of what this will go over. And then out of every year, about 300 out of those 60,000 are deaths here in Montana. So, and when you're actually looking at kind of those death statistics, especially for kids, that's kind of one of the top 5 causes of pediatric death. And even in adults, it's one of the higher ones. So.
And then also just think about the relevancy of just Montana in general, right? So like, you know, if you compare Montana to like Pennsylvania or Rhode Island or, you know, one of those smaller states, you know, since we're in a more rural area, you're typically with your patient for longer, and you actually have to do pretty solid airway management, even at the BLS level, for like long periods of time. So that's one reason why this class is particularly relevant to people in a rural setting.
So what is EPIC? Basic understanding of it is it's a treatment protocol. It's a guideline of proper ways to treat TBIs. And the big reason that it's kind of this whole thing is it creates a linkage to the care that you guys provide that directly correlates to surgical procedures. And both of them create kind of their own survivability stats. But the care that you guys give, we're actually finding that if you're doing it properly, will create even more survivability chance than even some of the surgical procedures that will end up happening later on down the road. So this is kind of that link to make everything work together.
And then this slide's just kind of describing how it started down in Arizona, and has slowly started to make its way across the West. So, somebody from Arizona? Are you?
Yeah.
Where are you from? Born
and raised in Arizona. I'm from Palomitas, which is near Cervista, which is near Tucson. So I went from small.
Like, I'm just gonna build up until somebody recognizes a name.
So this is just kind of a general breakdown of the study, but it's pretty much just like any study you would imagine of. They saw the problem, they did a risk analysis of it, they began doing the study, and then just kind of improved from there.
So basically the main point of this is that this is data driven, it's evidence based, it's not somebody that just made it up. Like, there is actual data that shows that this matters. And this is important because, you know, everyone in this room has been taught, more or less, you know, if you've been a paramedic, EMT, nurse long enough, you've been taught that, you know, hyperventilation in TBIs is the way to go. And essentially what this is going to be teaching you is the opposite.
So this is, again, just some stats on kind of the studies of how many different agencies, how many different patients they actually looked at, and all of the stats they were looking at is how is hyperventilation actually affecting the patients versus hypoventilation versus normal ventilations. And just so you can kind of see again with what he was saying, the data driven, how many different patients they actually touch to really prove the evidence that they're giving you.
And then one of the really big key takeaways for this slide is obviously the H-bombs, right?
Yep.
So that's really what we're focusing on. Are we preventing and treating, you know, hypoxemia, hypertension, and hyperventilation? So as long as we get those things, here we go.
So going right along with the H-bombs, the big one the first big one that you want to kind of prevent is hypoxia. So again, maintaining their SpO2 above 90%. 90% or greater is that range that you want to sit in. What they're finding with these studies is even a single episode of hypoxia under that 90% will increase the chances of mortality greatly. So if you can keep their SpO2 higher, it just increases that chances of survivability. big thing is pre-oxygenation. Don't be afraid to oxygenate your patient as much as possible. So if you have someone still stuck in a car that's being extricated, get the oxygen on them while they're in the car. Don't wait, don't do anything like that. The sooner the better, and one big thing that people kind of fall into that this is finding is the trap of someone gets into a car wreck and then they tell you, well, I don't know if I lost consciousness. But they're sitting there, they're talking to you, everything seems okay. So what'll end up happening is people don't put them on oxygen because, well, they're sitting at 96 and they're up and talking, but they haven't progressed into the full TBI symptoms yet. And that's the problem, is once they crash, it is a very sudden crash into all of those different symptoms that you see. So if you have any inkling that a TBI might be kind of in their future, just get them on oxygen, because especially in kind of this field of EMS, emergency department, that stuff, too much oxygen isn't really a thing. So just give them as much as you can, and it'll benefit them as you progress. So then big thing too is basic before you go advanced. And it just kind of really hits home on that of if they're not really awake, not really breathing on their own, throw in an oral adjunct, throw in a nasal adjunct, and use your BBM. And if that's working, stay there. Big reason is because as you progress into some of those more advanced techniques like intubation, you're increasing that risk of them going hypoxic because you're not providing those ventilations. So if your BBM is actually providing good oxygenation, stick with that. It's going to do the job just as well as you need to. If the BVM ventilations are inadequate and you actually can't get their SpO2 to start coming up, then that's when we need to start thinking of some of those more advanced techniques.
And then also, as the slide mentions, caveats, like if you have a super long transport, we're talking 30 minutes, make sure you establish a definitive airway for sure. And then also, that's of course dependent on skill level as well. So go with basically the most advanced skill level that advanced airway that you can handle at your level. So for most of you folks, I assume EMTs, right? Is there any medics in there? Medics, sweet. So yeah, you guys can innovate, and then you guys are probably signed up for like King LTs, like superclonic airways, that kind of thing. Yep. So always worth considering.
The next stage problem is hypotension. So again, it's just all about getting actual proper perfusion going to the brain, getting all of that cerebral perfusion going. So you want to maintain them at kind of a minimum systolic blood pressure. So for adults, which this one's mentioning, is no lower than a systolic of 90. That's kind of the level that you want to stay at. And the treatment that they're recommending for that is if you're anywhere below that, start with an initial bolus of a liter, and then follow that up with 500. And just keep giving them 500s to get them up to that level, and then once you're there, maintain.
So I do want to kind of take a pause here and put on our thinking caps and maybe get off trail a little bit from the EPIC class. If you have a seriously injured patient and they're hypotensive from hypovolemia, what is your protocol? What is your instinct for fluid resuscitation? What are you guys thinking?
Look at the map versus the actual blood pressure.
Yeah.
We restrict fluid.
Yeah.
Although this has this kind of reevaluating the setting.
It's an interesting consideration because essentially what this is telling you to do is to give like 1,500 milliliters of fluid and then more, right? Which for traumas, if it's a hypovolemic kind of emergency, is probably the wrong answer, because even though you want to maintain their systolic blood pressure above 90, in doing so, if all you do is flood them with pasta water, you're just going to blow every clot out, and you're not going to survive anyways. So it's worth considering if you have TXA as an option, if you have blood products, those kinds of things are definitely going to make a big difference. So like it might be the kind of thing where maybe you're calling in one of the life flight birds because they can carry whole blood, that kind of thing. They can come in and actually provide the fluids that are going to be beneficial to the patient, and not just let's just blast them full of spaghetti water and watch them fucking
We do
bleed
carry
out.
TXA.
TXA is a good choice.
If this is one of those things that ties in with TXA or not.
Yeah, this is honestly of all the EPIC TBI stuff is really great, but this is the one slide where it kind of makes me pause and I'm like, Yeah, but not realistic,
Not
you know,
real.
if it's in the field. So now, on the other hand, if this is not a hypovolemic kind of situation, where let's just say somebody has just a head injury and that's it, there's no blood loss, and but their SPP still dropping, that's when you would consider maybe giving in those boluses to bring them up. So just something to keep in mind, and then just that way you're thinking critically, like when you're dealing with your patients, you're not just thinking to yourself, oh, TBI injured, that always equals massive boluses of fluid. It doesn't always mean that.
So were you saying like if it's below the 90,
Mhm.
before you do the crystal loads or like the sugar water stuff, then you do the TXA?
So
Am I
that would be
understanding
at the paramedic level. They would be administering TXA, and what that essentially does is it promotes your clotting cascade. So that way, essentially, if you have somebody who's hypovolemic and their blood pressure is low because of a loss of blood volume, and especially if it was a thoracic injury. One thing you don't necessarily want to do is start giving them giant boluses of fluid,
Right.
because that will temporarily elevate their blood pressure. But what's probably happening is all the clots that are naturally forming inside the thoracic cavity are being blown out, so they're just going to bleed out anyways. And that fluid is not oxygen carrying anyways, so even though your blood pressure is higher, it's not actually helping them. You know what I mean?
Mhm.
So just one thing to consider, when you're looking at your patients, make sure you're evaluating whether you're giving fluid or not based on the patient presentation. So if it's just a head injury and there's no blood loss, there's no fluid loss, then I would say the boluses are acceptable. But if it's a head injury plus hypovolemia, make sure you're going with the correct course of action there.
And this slide, it's going over exactly the same idea, but for patients under the age of 10. So the thing that changes is obviously your fluid bolus dose. So the dose that they're recommending on your boluses, starting with 20 cc's per kilogram, and then your follow-up doses are at the 10 cc per kilogram. Again, everything that he just mentioned plays into this just as much as it does in an adult. However, the one thing that also changes is that systolic blood pressure. So rather than sticking with that hard 90 like we do with adults, there's kind of a math equation that you do to get your minimum systolic for peds, and it's 70 plus 2 times their age. So when we go into like the pre-test, when I was asking about the 5-year-old, 5 times 2 is 10, so that's how you get that 8, and that works for pretty much any pediatric patient that you're dealing with from one up. So here's the fun one, hyperventilation. So I'm gonna ask, do you guys know why hyperventilation became a thing, why we started teaching people that for TBIs?
You're looking at me.
Anyone?
In
Yeah.
general.
To cause vasoconstriction, decrease the pressure if the patient was herniating.
Yep.
Absolutely.
Yep.
So, and the actual study, the actual reasoning behind that started in the 70s and has just kind of progressed up until the 90s. And it was in the 90s that people started looking at, are we actually causing what we want to cause, or are we causing injuries? And especially in the early 2000s is kind of when stuff like this started to take off and they really started to look at it. And what they were finding is that although the hyperventilation was doing exactly what we thought it was doing, if it's causing that vasoconstriction, it was causing vasoconstriction to such a degree that we're actually decreasing that cerebral perfusion. So you are essentially causing hypoxia itself to the brain.
So you're actively killing neurotissue by doing exactly what you wanted to do in the first place. So it's totally counterproductive. I mean, it kind of makes sense if you think about it, because you're trying to reduce that pressure, right? But ultimately what's happening is you're still causing neural death. So
And then obviously it gives you kind of the rates that you're wanting to actually ventilate your patients at. So adults is 10 breaths a minute, kids you're gonna go to the 20, and then infants you're at 25. The biggest thing, which we'll hit on it a little harder on one of the slides coming up, but the biggest thing is when you're actually bagging someone at this rate, it feels so slow. And one thing that they'll hit on is it's easy to do it right once, it's hard to do it right consistently. Especially when you're actually sitting there with this patient in front of you. That's been the hardest thing, is actually consistently keeping it. So kind of making more of a conscious effort to really count those respirations and really slow yourself down. It'll feel like you're hypoventilating your patient, but really these are kind of the breaths a minute that you're looking at.
And the reason we have these BVMs here, and the reason there's a blinking light up on the screen, is that these are specially designed pieces of equipment that help you control your rate as you're actually breathing for your patient. And then also, remember, you can use those additional data points, right? So your end-tidal CO2, if you're monitoring your patient's end-tidal CO2, you just make sure you're hitting that target range, and you can adjust your rate of breathing accordingly. Yeah, let's go for it, yeah.
So I'll actually pass these around so you can look at them. I'll show you guys the PDF. So when you actually, so there's a light that's on top there. That light will actually blink at the rate of whatever patient you're dealing with. So the adult PVM blinks at 10 a minute, the pediatric ones blink at 20 a minute. So you actually have a light to look at to measure how fast you're breathing. And then the other thing is, with hyperventilation, you're also not wanting to put too much oxygen into your patient too quickly. So they actually have a fail safe on it. So if you squeeze too hard or too quick, it actually pushes a pin through it and stops all air that you're giving from being administered. So these were specifically designed to match up with Epic itself. So
I've gotten to use these, and the timer is like the most helpful thing.
It's pretty great, huh?
it really is. Again, it's hard to do consistently by yourself.
It's kind of, it's just like having a metronome on like a life pack, you know, it's just going in the background and you just match it perfectly, you know? Yeah.
It is helpful that the Lucas device also has that guiding light.
Yeah, absolutely. Yeah. I'm one of those guys that tends to just move a little too fast when I do CPR, so I always need something
I
like
think
that.
everybody does,
when you would
yeah.
actually want to use it, you
Once
put
more
this little
adrenaline starts
guy
pumping,
out,
you're just
and
like,
this light
yeah.
right on
Yeah.
top blinks.
I get after it.
Oh,
Yeah.
okay. So
Usually,
just doing-
if with these bags, when you get them, usually the light isn't actually already on. It just comes separately. So that's one thing to always kind of remember if you do have these bags, is when you first pull it out. If the timer's not there, it's floating around somewhere. So
Yeah. And, you know, it still functions as a normal BVM, even if you don't have the timer on
Yeah.
it, so.
Now those little lights, our BVMs don't take those, just the way they're designed.
Right, so,
We
the
base things
cool-
on other surfaces because, I mean, could you just not put it on something else and look at that?
yeah. So the back of it is just a sticky pad, so you can stick it wherever you need it to.
And the cool thing about this
Yeah.
course is you guys will be provided those BVMs, I'm pretty sure, at the completion of this, once you guys are ready, so.
Yeah, once we have 80% of the team trained. The problem with it is the battery sticks down a little farther than the
Yeah.
adhesive ring.
Yeah.
And so we've had trouble, you know, with our existing bags.
Right.
And so in our hospital, we're required to kind of carry the same bag. We have limited storage for supplies, so they want us using the same bags the hospital uses. I tried to guess a switch to these, but their capnography is different. We use, you know, the
Oh, sure.
inline, and they use the one that kind of plugs into the side of the, and so they don't want to switch to it because their capnography won't work. So
Right.
I'm gonna see if there isn't some type of similar smart bag that would take their form of.
Yeah. Or even maybe just, you know, bulk LED lights that blink at a certain rate.
Right.
On Amazon
Or
or
just buy
something.
the stickers, like they'll stick on the places.
Yeah.
But what is cool about that is it does have the safety feature, right? So you
Right.
can't,
Sure.
it's not just the light, it's the actual safety feature.
That's
Yeah.
just my pet peeve, is watching people, like, I work at St. James, and watching people come in and breathe during codes, and they're just like cranking on that.
Yeah,
You're
just
killing that
completely
guy.
crushing it.
Yeah.
Just 900 milliliters. All right, so you can keep going.
Let's do it. All right. So, along with the hyperventilation part, one of the metrics that you'll use to kind of monitor how you're breathing is end-tidal. So, as we kind of mentioned with the pre-test, that range that you're looking at is 35 to 45. That target is 40. You want to be right in the middle. And obviously, if the end-tidal is dropping, that means you're breathing too fast for him. If it's rising, you're breathing too slow. Just try to keep it right in that target. And this just goes along right back with the increase of pressure or the, I'm having a stroke.
Well, this is a good place to do it.
So it goes right along with the vasoconstriction that leads to the lack of cerebral perfusion. The big thing that actually, the pathophys of actually causing that vasoconstriction is a decrease in CO2 partial pressure. So if you're letting that CO2 drop, you are essentially, again, causing that decrease in pressure, which causes everything else to happen.
CO2 is like one of the most, end-tidal CO2 is one of the most accurate predictors of like patient mortality rate, just in general. So like, I forget exactly what the numbers are, but it's something like if somebody's below 20 for like X number of minutes, their mortality rate goes up to like 90% or something like that. Like it's really high.
Wow.
So you always want to really keep a close eye on that. You know, it's super easy for people to just throw in the SpO2, and that's, you know, our go-to as, you know, EMS providers. But oftentimes your most accurate data point that you can get is just an end-tidal CO2. So if you got it, definitely use it. And that's even at the VLS level too, obviously.
So this,
More data stuff.
yeah, it goes right back to the data of what they collected. So the next couple slides are just articles that they've kind of published in the past that just show, again, the relevant data points on all the studies that they've done.
And in your book, there are references at the back if you want to look all these up. So basically, this is the most important part. This is what they found out through the research and through the studies, right? You just need a lower rate of innovation, despite your greater injury severity. So basically, only, like we were mentioning on previous slides earlier, intubate only when you need to. Don't just intubate every single patient. Making sure that you're choosing the correct airway adjunct for your patient. Much higher rate of BVM only airway management, but still had a really good outcome, and a greater likelihood of having higher SpO2s, greater reversal of hypoxia, so on and so forth.
And just as a good reference point too on kind of the ventilation part of it too, when they're talking better BVMs, lower rate of intubations, just as a reference point of how important it really is, that proper BVM ventilation, if they were just looking at patients that were being bagged and weren't intubated, proper ventilations actually doubled their chances of surviving. And then in the patients that did require intubation, that had the proper ventilation along with it, tripled their chances of survivability. So just by this one little change,
Yeah.
that outcome.
I do wonder, and part of this was not addressed, I don't think, in the data, in a lot of the research for the EPIC studies, at least that I've seen so far. But intubation competency is kind of hit or miss just across the nation, just in general. So like, you know, if you're a medic who's just been dropping tubes for years and you're really freaking good at it, I mean, maybe you can be more judicious with which patient you're putting in your tubes. But if you have a lower skill level and like maybe you just don't really intubate that often, like maybe you only get like 3 or 4 a year, maybe it's better to just skip the intubation that might be difficult, especially on these patients, particularly these patients, and just go with really good BLS supportive kind of care. So just something we're thinking about.
So exactly what I just said.
This slideshow has become kind of redundant, in fairness.
Yeah. So there's your average EMS affected survival rate. And kind of the big thing with this too is, along with the survivability rate, kind of the opposite end of the spectrum too is mild to moderate TBIs, so ones that they're still going to have possible some deficits from it. One episode of the hypoxia or even mild hyperventilation. So, you know, we're talking instead of 10, you're doing 13, 14 a minute. Even that little bit of a change will increase that mortality morbidity significantly. So that's one of the big reasons that this is kind of important. Of the skills behind it matter just as much as how fast you're using the skills.
Can you repeat that? So one episode of hypoxia or hyperventilation, is that what you
Yeah.
said?
And then your pediatric survival TBIs had a 5-fold increase using these techniques.
Means a lot.
Yep,
I think that's the big thing is the dramatic change that just a little bit of PBM can do. Is.
And these are just your key takeaways. So. One of the important things, right, is it's saying effective interventions are really simpler and expensive, but in this case, absolutely are, right? Just watching your 3H bombs and just making sure that you're treating accordingly. And, you know, it doesn't require a fancy new piece of gear. It's not like people going out and buying a Lucas device or something like that, right? It's just the same old BVM you've always had and the same old life pack. You're just using them, you know, with these techniques. And then, of course, you can do it anywhere. And as Rob was saying, it's very hard to do. It's going to feel like you're hypoventilating your patient, and it's going to feel like you're not doing proper care. It can be scary because you want to get your most aggressive airway in as possible, but you know, we're trying to open people's minds up a little bit to thinking, slow down a little bit, take a breath, and make sure we're choosing the right, you know, treatments for our patients. And then, of course, stakes are high.
Yeah. So, big thing that you've already kind of mentioned a little bit, obviously, are the two different types of injuries that you deal with in TBIs. So the first one being your primary injury, which is the actual cause of the injury. That's, you know, your explosion, your car wreck, your fall, whatever it is. The secondary injury is what this is specifically identifying, and that's the injury that comes later from the hypoxia and the decreased cerebral perfusion. And again, through all the studies and all the patients that they looked at, they were finding that people were focusing more on the primary injury, right? We need to get him to a hospital where a surgeon can deal with the primary effects of it. But what they're finding is the secondary injuries are just as, if not more deadly than the primary injury itself, just because you're causing so many other effects. So doing the ventilations properly, keeping them not hypoxic, not why am I having a stroke today? Keeping their blood pressure at the correct level, all that kind of stuff, will have just as much of an effect on them as a surgeon actually going in there and dealing with what they need to do. So.
All right, so primary brain injury, right? We all have learned about this kind of stuff. Just a quick refresher on what TBI is just in general, right? So like your primary brain injury is actually just getting hit, or if you are in a car wreck and maybe you don't hit your head, you still slam forward at high speed, your brain's still rattling around inside your skull. There's going to be just TBIs just in general, right? So kid gets hit in football, somebody falls over while they're skiing, like all these kinds of things. Those are your initial injuries, right? Your secondary brain injury, of course, is what's caused after the initial injury. So that's what's caused by hypoxia. So again, neural death by not receiving enough oxygen, and then just poor blood flow from hypertension and hyperventilation. All of those have a major impact. And then do everything you can to prevent the secondary injury. So first injury is out of your control, obviously. Secondary injury, that's where we're trying to intervene, and that's where we have the most control. Yeah, deliver alive patients, essentially, is what we're saying.
It goes back. It goes back to what I mentioned at the beginning. It's that link between what we do and what the surgeons will do. It's just that direct connection, and especially if we do this right, that makes the surgeon's job so much easier as well. So,
and good for recovery. All right. So, who is your epic patient? Trauma, even ground level falls. So elderly folks, right? They're living in a nursing home. They take a, you know, if they're 6 feet tall, they take a 6 foot fall. You know, that's definitely a TBI kind of person, kind of candidate. Excuse me. Any loss of consciousness is somebody who's a candidate for having a TBI, even if it's just out for a few seconds. They saw stars, just lost control, and then obviously any altered mental status, repetitive questioning, blown pupils, obvious MOI, big gash on their head. You know, those are your TBI patients. Like Rob mentioned earlier, you know, when we're talking about the oxygenation section, you know, just making sure that you're oxygenating all of your patients, just even based on MOI. Just keep that in the back of your mind. Like, you know, one of the things that goes chronically underreported and just is not documented well is high instances of TBI just across the board. Just people are just really injuring their brains left and right, but everyone's always been conditioned to think that, like, unless they've been knocked out, you know, or they have a really obvious concussion, then they're not thinking that, yeah, it's a TBI that can be pretty serious, right? Especially in like elderly folks, you know, you just have to be really mindful of making sure that anybody who has significant MOI might also have that TBI. Seizures with trauma, multi-system traumas, and then obviously your risk factors, older age, and then anybody who's on those anticoagulant medications. And then if you don't know if they had loss of consciousness, just use MOI and treat it as if they were.
It gets important, especially as you get into some of the deeper head injuries. I won't go off into that tangent, but there's those specific head injuries where they're going to have that loss of consciousness, and then there's going to be that lucid period where they're awake and they're with you until they crash, and that's that once it happens, and that's kind of the big thing here.
Yep.
You might not remember being knocked out because they're already in that lucid period relatively quickly. You won't know the full extent of it until everything progresses. You'd rather be ahead of the game than fall behind.
Yep. And then those are your basic EPIC algorithm guidelines. So a little bit too much for that slide. And then as we've talked about, oxygenation is critical. And then key numbers, again, keeping that above 90%. Apply to early, and then early and ongoing high flow non-breather. Oxygen can prevent hypoxia in your patients who deteriorate quickly. Even with good mental status. I think that's probably the biggest takeaway from this slide. Is even if they have good mental status, just offer them the oxygen. And that might be, you know, we work EMS. We know what difficult patients are like. They don't want to. They just want to get their insurance card. They want to talk to High Patrol. They don't want to mess around. But you know, try to be an advocate for your patient. If they're just not having it, and they're NO times 4, you know, that's on them. But you know, if you can, try to, you know, really convince them. Hey, just get some oxygen here. Just take a breather. Take a breather. Sit with me for a couple of minutes. Let's chat, and then get a really good, like, you know, assessment of what their, you know, mental status actually is, and make sure they're actually getting some good oxygen.
And I think that really goes along with the one word up there, aggressive oxygen. I think one thing that people lack sometimes.
Don't chase them down with an NRB and like smack it in their face.
But I think it falls kind of into two categories of how people see that. It's either exactly that of you want to make sure they're getting the oxygenation, but again, if you have a difficult patient, that aggressiveness also goes into how you communicate, of making sure that they understand what you're trying to do, versus just using that as a, well, they don't want oxygen, so I'm just going to let it be.
We've probably all done that. I know I for sure have done that. Where like somebody who, I mean, they've really probably rung their bell, but they're times 4, and they're saying, dude, I don't want to go in the hospital, or I don't want to go in the ambulance, I don't want to go to the hospital, leave me alone. I'm like, okay. And I should have, you know, taken probably a couple extra seconds, maybe even a minute, just, you know, work on it a little bit, just to, you know, not because it's good for me. You know, I don't need to do the paperwork.
Well, and that-
it's all about being an advocate for your patient.
The situation we were talking about with John, like he's an old rancher, I mean, And I did that, and I kept checking on him and checking on him
Yeah.
and checking on him. And I even explained, you know, injuries can happen once that adrenaline goes down.
Yeah,
You
absolutely.
might be hurting somewhere that you didn't hurt before. So then, you know, call,
Yeah.
I'll check on you, or, you know, whatever. But
Well, and people are stubborn, right? So, yeah.
Ranchers
You don't
are
want to feel like
stubborn.
you got your belt around you. You just want to, you know, grab on with the day. But all right. Little scenario here. So this patient had loss of consciousness, a lot of time spent with EMS, but he was awake and chatting with them. Probably with EMS for about 30 minutes, but they didn't put oxygen on him at all. Now they're putting him in a helicopter, so they're taking him in an unpressurized cabin at altitude, which is definitely going to lower his blood oxygenation, and he's not being pre-oxygenated at all. So, you know, this is pretty ideal situation for those H-bombs to sneak in there and like really leave some lasting effects, whereas this might have been prevented. So, especially around these areas up in the mountains, be really conscious of that and make sure we're pre-oxygenating before they get on a pressurized aircraft.
And this is like that best example of looking at your mechanism and getting kind of that feeling in your gut of, like they said, no one else in that other car survived. If you have that right out the gate, it doesn't matter how good your patient looks, you should automatically assume something else is going on. Let me treat him as aggressive as necessary.
And then we've harped on this already, but just be really good with your BLS care. And then just, I wouldn't say cautious is the right word. I would just say just be smart about it. Just be judicious. You know, use it sparingly. So. And then your tools for success. Flow control to reduce volume BVM, so making sure we're only delivering volumes that make sense for our patient size. Make sure you're using the timing light. If you don't have that, just make sure you're being very cautious about how you count out your ventilations. Obviously, we're trying to maintain that target end-tidal CO2. A VEMT is kind of interesting. That's basically some ventilation spotter. Basically, what this is saying is just like you would do a CPR. How somebody, if they're watching you give terrible compressions, they're going to call you out, or not even call you out, just going to say, hey, you need a break, can we swap? I think you need to slow down, you need to go deeper, you know, that kind of thing. Like, make sure you have somebody, or if you're with somebody, just check on your partner. Like, if you see them just mashing that bag, be like, hey, dude, slow down.
And one thing with that too is, like it said with the ventilation spotter, is that's if you have sufficient hands to do that. One of the biggest tricks I always use, if let's say it's just you and a partner and that's all you have, if you're the one doing ventilations, make sure the monitor that's actually reading your end tidal is in front of you, so that there's none of this turning or looking. You can maintain focus directly in front of you and still see everything, but what you need to focus on is right in your view.
And then it says early ventilator use, so if you have access to ventilators, I don't know if you guys are carrying those on your
No,
trucks at all.
ambulance,
Okay,
no.
yeah, but if in the future you find yourself working for Life Flight or some other critical care kind of service that has ventilators, you know, if we're gonna go with an ALS intervention like intubation, and you have a ventilator available to you, hop on that ventilator quicker rather than later. So. And then go to prevent your hypoxia during intubation. 2 minutes severe secondary injury can be life-changing. So, if you choose to intubate, yeah, just putting the tube in isn't the whole job. Obviously, make sure you have your BVM, and then really make sure you obviously follow the basic steps, confirm placement, make sure it's actually in the right spot, and then once you confirm, just really watch that end-tidal CO2. Talking about some little specifics for kids.
this is essentially, again, a repeat slide of what we already went over
For the adults, yeah.
But the big thing of, again, why they repeat the slides like this is they really want to hammer that point home of just these 3 things, always keeping an eye out for.
And then key takeaway for this slide is your systolic BPs. So infants, you want it to be 70, 5-year-olds 80, 10 and older, same as adults treated. All right, sedation and pain control.
So this is one of the more interesting ones, especially for our medics. Being very cautious with your sedation and pain control. Again, for the exact same reasons of everything we've been talking about. Of the hypotension, the drop in blood pressure just kind of contributes to that decreased cerebral perfusion. So, obviously, go ahead.
No, I was going to ask if you guys have sedation medications. Do you have RSI and anything like that on your ambulance?
We don't RSI. It is my goal to get us to that point, but
Yeah.
that's it. But we do help out in the ER a lot. You know, since we're hospital based, we wind up assisting with our RSIs here, and I tend to lean towards ketamine.
Yep.
For the less, you know.
Ketamine is
drop in blood pressure.
fantastic, yeah, absolutely, for head injuries. It's basically has almost no effect, so it's like a perfect disassociative for head injuries. The little ketamine Versed combo, I mean, for the field, if you guys are authorized to give that with your protocol.
We carry them both.
Yeah, I mean, it's great in the field, so really good disassociate. It's obviously not a paralytic,
Right.
so, you know, they'll still have their, you know, vagal response, but it is a really good option if you have it available, so.
So it's all just about being cautious with it. And again, you might run into that patient that he's awake, he's talking, everything seems fine, just hurting a little bit, and you might get that feeling of giving them some pain meds. But back to the aggressive treatment with oxygen, it's still be cautious with kind of the meds. And it's not saying don't give them, but it's saying you have to really make sure that blood pressure is actually what you're seeing it is, and then maybe not getting the dose that you give. I think one of the slides it talks about starting at like a quarter dose. So just starting real small and just incrementally increasing it, just so you don't cause any of those secondary injuries.
Yep. And then just put that in the context of what a call might look like. If it's a car wreck, the guy's got a broken leg and he's screaming about it, but he also might have a TBI. Just be conscious of what pain medication you're selecting for that injury. So. And then sedation RSI.
Yeah.
Just skip that. Big takeaway from this slide is just start with your lower dose and then work your way up. So.
And it goes back to the BLS before ALS too. If you can get away with positional comfort, just do that then and stay away from the meds. But if you absolutely have to go to meds, just kind of be careful with that.
Another big takeaway from this slide is that your reversal agents don't reverse your vascular effects. So, if you overload somebody with an opiate and then you end up throwing on some Narcan and reverse it for whatever reason, it's still not going to 100% reverse all those vascular effects. So, just something to keep in mind.
So, again, repeat slide. Yeah. Don't hyperventilate.
I know. It's 60 slides and like 30 of them can be cut out of this presentation.
And you said you'd email us these?
If you no, the textbook.
Oh,
Like the textbook.
because I wanted to give some to Yvonne Elliston. I just think it'd be good.
The
And
textbook.
they're not here.
Yeah,
If
sure.
you want, I've created the classroom portion for this class, and after today, I was gonna issue it to all of our crew that didn't attend.
Oh.
And so I could.
And that's actually why we're recording as well. So
Oh,
that
perfect.
You guys are recording.
So yeah, I can share that with your crew if they wanna.
Good, because this is the second one I've missed.
Yeah, you might even be able to knock it out while this first session is going, if you want, so that you're ready before the hands-on.
All right. Herniation.
So, herniation is one of the interesting ones because it's a TBI that's progressed to such a level that the injury is extremely significant, right? So obviously you're looking at those different symptoms, hernia, the pupils, the odd ventilator, yeah, thank you. I'm having that stroke day, but your bradycardia and all that kind of stuff. One big takeaway of it is, since that's a TBI that's already progressed to
Well, thanks for joining us.
Years.
Glad we didn't completely wait for it.
Right. Just a quick question. Are you guys, you're familiar with what herniation just in general is, right? So everybody's on the same page. Sorry. I realize we kind of blew right past that definition. I just want to make sure everyone's on the same page. Okay. Yeah.
The hard thing with it is, being that it's such a progressed injury, it's like it's saying up there, it's an ominous prognosis. Like there's already, death is highly likely by this point. So very little that we do in the pre-hospital emergency department world will actually affect reversing that, whereas all the other stuff we're talking about does. Big one with this though is, even though the proper ventilation might not necessarily help, you still don't want to hyperventilate, because you just don't want to make it worse. And that's the big thing, because if they're already in, you don't want to speed up that process.
Absolutely. Right. 5 good takeaways. High flow to and all injured patients with the loss of consciousness. Keep your systolic blood pressure above 90. Be cautious with your sedatives, and then just be cautious with your advanced airways. And I like this sentence, be maniacal about preventing hyperventilation. Now this is important. Okay, so 5 things that you should be documenting as you're encountering these TBI patients. So make sure you do a good Glasgow Coma score. So you want your 2, so at least a minimum of 2. So establish a baseline when you first, meet your patient. You start, having your first interaction with them, and then of course that's going to happen. If you're for the RNs in the room, like when you first meet your patient in the ER, take a baseline Glasgow Coma scale right away, and then you can compare that to the EMS folks if they did one. If they didn't do one, which oftentimes doesn't happen because you just, things get lost, then take another one like 15, 20 minutes down the road. That way you can compare. So it's just, like getting vital signs. You just want to make sure you're watching that trend. Get your blood pressures. Make sure you're being really cautious with getting those at least every 5 minutes. Continually assess your SpO2, cat blood glucose if you can, and then most important, get your end-tidal CO2. And your performance and process indicators, just make sure you're identifying your TBI early, and then choosing the right treatment. Same thing. Good positive pressure ventilation as needed. Utilize your fluid resuscitation protocols as needed to get the systolic blood pressure above 90, like we talked about. Make sure you choose the right route, IVIO. In traumas, you guys probably already go with standard. I'm assuming at least 18 or 14s for your IV gauges. So just make sure you get your large bore IVs, and then go IO if you can. And then glucose, obviously good blood glucose.
I think one of the other things too with being good with the process is the communication that you have with everybody. I think it's extremely easy when you have those patients that are super injured to be able to communicate, like, this is how bad it is. It's those patients that we've been talking about that are subtle, that are still awake, they're maybe a little confused, just I don't know if those patients, if you have that bad feeling wherever you're at of how they are presenting, making sure to communicate that feeling to whoever you're transferring them to. That way they're not just looking at, their chart or whatever was written down and saying, oh, their vitals are fine, they're answering questions fine. A lot of this is kind of that feeling to it. If you're out in the field and you see the mechanism and you think it's bad, even though their GCS 15 vitals are fine, relay that of like, this was traumatic. Like, there could be something else that way, even though they might not necessarily prepare for it, it's on their radar. So.
And then this slide just talking about EMS agencies becoming certified. Once 80% of the personnel in that agency have been trained up on, they've gone through this class, and then hopefully had a chance to at least practice it once or twice on the simulator. They can be signed off, and then these smart bags will be provided to your agency and carried on the trucks. So. And then you'll be recognized. Good for you.
Good for you.
And then
Yeah,
the best.
we want that gold star that goes right with the neck, the
So
one we already have.
I'll print one of these slides up and I'll just cut it out. And then you guys can fight over who gets it, and then we'll tape it on you.
No, we just need 3, 1 for each truck going right next to the other gold star. We'll get that gold hood light with gold stars.
I think the biggest takeaway, though, honestly, from this slide is just it's just current evidence-based medicine. This is just medicine. It changes, especially in EMS. So we're just trying to do the best we can to keep up with things as we learn about it.
It does a lot.
Yep. All right. Kind of our key messages here. Kind of wrapping up our slides. I think we beat you over the head with this. If you don't know it by this point, I don't know. Just quick refresher. What are the 3 H-bombs?
Hypoxia, hyperventilation, and hypotension.
There you go.
Beautiful.
All right.
We should have 3 more slides on that.
I think we might need to go over it again.
Just a couple.